Good morning, and thank you for joining us back for the second part of this webinar series. This webinar is presented by Practolytics in collaboration with Advanced MD as part of our provider education series. Advanced MD is a technology provider which helps healthcare providers and facilities with cutting edge technology in terms of practice management and electronic health records, which enable physicians and practices thrive in their day-to-day activities in their practices. Practolytics is a 20 plus year old organization providing extensive revenue cycle management services to its clients across 26 states in the United States. We cover multiple specialties and we help providers improve their practice revenue and also catch up with the ever changing relations when it comes to compliance and insurance related changes. We also offer a range of solutions designed to help healthcare organizations analyze and interpret data in order to make better informed decisions. This is the second part of this webinar series. In the first part, we spoke about the changes in CPT codes specifically related to observation and inpatient care. In the second part, we will talk about the changes in guidelines when it comes to documentation and selecting the level of code based on the medical decision making. We tried to we tried our best to provide the most accurate information throughout this webinar series. The information provided is for educational purposes only, and we would recommend referring to the official guidelines which were published by both the AMA and the CMS to ensure that you have all the important information related to these updates. So let's get started. So, for the year 2023, medical necessity takes the driving seat, and when it comes to code selection, the medical decision making becomes the most important part of it. The primary objective of the 2023 evaluation and management revisions is to provide consistency with the revisions that were made in the year 2021 to the office and outpatient services. So for 2023, revisions have been made to the rest of the ENM code categories except for critical care services. So this major change is to ensure that all the ENM code categories align to the same concept of selecting a code based on medical decision making. So the major change that we saw in 2021 for outpatient services and now in 2023 for inpatient services is the documentation of history and physical examination. That's the first thing that has actually changed. So the level of history and exam are now changed to only a medically necessary requirement and do not play a role in selection of the ENM codes. It's now the level of the medical decision making that decides the overall code for the ENM services. So history and physical examination, they are still required. However, they are not used to determine the ENM code selection or the code level. A medically appropriate history and exam should be documented for each encounter, and the nature and extent of history and examination are actually decided by the treating physician. And also, apart from the medical decision making, time can also be used now to select the level of ENM code for inpatient services. However, the time requirements have changed significantly for each code set. So starting January of 2023, there are changes to the medical decision making table specifically focused towards inpatient set of CPT codes. These changes play an important role in coding evaluation management services. So we'll have to take a deeper look at each of these changes or updates from the medical decision making table. So basically, we all know that the level of medical decision making depends on these three important factors: number and complexity of problems addressed at the encounter, we call them as problem points; amount or complexity of data to be reviewed and analyzed, we call them as data points; and the risk of complications and or morbidity or mortality of patient management, which we call as the level of risk. Now, two out of these three components should be met or exceeded to determine the overall level of medical decision making. And as I said earlier, time can also be used for coding inpatient services now. If the services rendered to the patient qualify for that amount of time required by each of these CPT codes, like the inpatient new patient evaluation or the initial hospital care evaluation codes 99223 has been increased by 70 minutes or more than that. So that time requirement, if it is met, then you can use time as the factor for coding the services. Now, even if you're talking about time, but you have to remember, medical decision making should always be the first criteria to be used for coding the E&M services. Time is only used in certain, exceptional situations. So, AMA has provided definitions on the number and complexity of the problems addressed by the treating physician. So, a problem is considered as addressed or managed when it is evaluated or treated at the encounter by the physician who is reporting the service. So, something treated today is what is actually counted. This includes consideration of further testing or further diagnostic workup or treatment that may not be elected by a risk or benefit analysis or just by the choice of the patient or the patient's caregivers or guardians. It all depends on the problem that is being addressed and what kind of treatment is necessary for the patient. Now, a simple note in the patient's medical record that another professional is managing the problem without documentation of additional assessment or coordination of care will not qualify as that problem being addressed or managed by the physician. So you cannot simply state that patient has a gastrointestinal problem and GI is looking at the patient's condition. That wouldn't be enough if you are trying to look at the patient and treat the patient. Now, another point is referrals. So, referrals without evaluation by taking history, examination, or diagnostic studies, or even the consideration of treatment options, does not qualify as being addressed or managed by the treating physician. Which means, if you are referring a patient simply to another physician for, a second opinion kind of thing, if you are not documenting any evaluation or examinations, that referral would not be counted as something which you have done. So you have to be more specific, and the documentation has to reflect that the referrals are actually qualified for evaluation and management calculations. Now, for hospital inpatient and observation care services, the problem addressed is the problem status on the date of the encounter, which may be significantly different than it was on admission. It could have been worse at the time of admission, and now it could be stable whenever the patient is seen, for the progress note specifically. So it is a problem being managed or co-managed by the reporting physician and may not be the cause of the admission of continued stay, which means the problem that was addressed today may not be the problem that was there at the time of admission. It could be something new or something different. Now, we will talk about the uh, three main criteria of the medical decision making, one after the other. The first one out of it is the number and complexity of problems addressed. So, multiple conditions may be addressed at the same time, and these conditions may affect the overall medical decision making. In some cases, symptoms. Okay, so symptoms may also lead to a specific definitive diagnosis, and in such cases, each symptom is not always necessarily a unique condition that is treated or addressed because there is a definitive diagnosis that is already there. So, a group of symptoms may lead to a single condition. That condition would be counted, not the symptoms. Additional comorbidities or other complications or other underlying conditions can be considered in selecting the level of E&M code only when they are addressed or treated, or the presence of such additional conditions increases the amount of data that needs to be reviewed, and also when such conditions increase the risk of complications of the patient's management. So, the secondary conditions or secondary diagnosis or additional comorbidities like chronic conditions sometimes they will be counted only when they are addressed or treated, or if they have a direct bearing on the patient's current condition or the current diagnosis. Okay, and one more thing, the final diagnosis for any condition does not always determine the complexity or the risk level. Sometimes Extensive evaluation may be required to reach the conclusion that signs or symptoms do not actually represent a highly, complicated or morbid condition. And this is the reason the presenting symptoms that are likely to represent a highly morbid condition may drive the overall MDM, even when the final diagnosis is not so complicated. So even symptoms play a important role sometimes, apart from the actual diagnosis that was identified. Now, the patient's evaluation and treatment should be consistent with the nature of the condition, and sometimes multiple problems of lower severity may also create a higher risk because they interact with each other. The level of risk or the term risk that is actually used in these definitions mainly relates to the risk from the condition that is being treated. Okay, this is the most important thing that you will need to remember when you're talking about the level of risk for medical decision making. So essentially what this means is that the risk from the condition is distinct from the risk of managing the condition itself. Okay, and assessment of risk of the presenting problem is actually based on the risk related to the disease process that is anticipated between the current encounter and the next encounter, and the documentation of the risk must be specific. So, what happened between the current encounter and the previous encounter, or something which is going to happen, is what is going to be key when understanding the subsequent hospital records specifically. Now, the physician has to indicate why they think the risk is at that particular level. Like, there needs to be a thought process of the physician, which is documented. And the documentation cannot simply say, like, it's a high risk or a moderate risk or a low risk problem. It has to quantify, or it has to specifically identify why it is at that risk level. So, the physician's thought process should actually be captured on the documentation. Now, let's look at the definitions in more detail. These are the definitions which have been established by AMA and have, this is how each of these conditions should be looked at when you're looking at the medical decision making table. The first one is self limited or minor problems. So these are conditions that run a definitive course. They are very transient in nature and not likely to permanently alter the patient's health status. They might go away on their own even with not much of a significant treatment. The next one is stable chronic illnesses. So these are conditions for which the expected duration is at least a year until the death of the patient. So chronic conditions generally are considered if they last for a year or more. And all such chronic conditions are treated irrespective of whether the stage or the severity changes. And for example, like uncontrolled diabetes and controlled diabetes, both are considered as a single chronic condition. The term stable for categorizing the medical decision making is defined by the specific treatment goals for an individual patient. Okay, and any patient who is not at their treatment goal is not stable. This is what you will have to remember. Okay, so even if the condition has not changed and there is no short-term threat to life or patient's function, and the risk of morbidity without treatment is significant, you have to consider that condition as not stable. Okay, anything that is not at goal is not stable. Now, the next definition is acute, uncomplicated illness or injury. So, a problem that is normally self limited or minor, but is not resolving and is consistent with a definitive and prescribed course, is considered an acute, uncomplicated illness. Such conditions are new, short term problems with low risk of morbidity for which the treatment is generally considered. They are short term and they may go away, but then with specific treatment. Now, there is no risk of mortality with treatment, and full recovery without functional impairment is usually expected. So, these conditions are generally acute, uncomplicated illnesses or injuries. Now, in similar lines, a stable acute illness, this is something that is new or recent for which treatment has been initiated. The patient is improved, and while resolution may not be complete, patient is still stable with respect to this condition. These conditions are stable acute illnesses. The other definitions, again, nature, number and complexity of problems addressed. So the next one is chronic illness with exacerbation. Exacerbation, progression, or side effects of treatment. So, a chronic illness or a chronic condition that is acutely worsening or poorly controlled or progressing with an intent to control progression and requiring additional supportive care or requiring attention to treatment for side effects. So, basically, a chronic condition with exacerbation. Now, another point you need to remember is if the chronic condition is if there is an exacerbation of the chronic condition, you might want to identify whether it's a mild, moderate, or a severe exacerbation, because there's a lot of difference between a mild exacerbation and a severe exacerbation, even for medical decision making process. Now, the next one is undiagnosed new problem with uncertain prognosis. So these are problems in the differential diagnosis that you generally see that represent a condition likely to result in a high risk of morbidity without treatment, which means this is something which is not yet confirmed or diagnosed as a specific condition and may lead to any sort of differential diagnosis or different conditions. That is an undiagnosed new problem with uncertain prognosis. The next one is acute illness with systemic symptoms. So an illness, acute illnesses that usually cause systemic symptoms and also has a high risk of morbidity without treatment. Such conditions are all acute illness with systemic symptoms. For systemic general symptoms such as fever, body aches, or fatigue, in a minor illness that may be treated to alleviate symptoms, you'll have to see the definitions for self-limited or minor problems, which means usually acute conditions with fever, body aches, or fatigue may not be classified as systemic symptoms because they are most common signs and symptoms. Then the next one is acute complicated injury. So, an injury which requires treatment that includes evaluation of body systems that are not directly part of the injured organ. The injury is extensive, or the treatment options are multiple and are associated with risk of morbidity. So, such conditions are acute complicated injuries, which means sometimes fractures or injuries that might require a significant neurological evaluation. Those kinds of conditions may fall into the acute complicated injuries or illnesses. Now, these are a few examples of the most common conditions for hospital inpatients based on the complexity of the problems and the amount of work and level of risk involved in the treatment process for these conditions. All the examples shown in the medical decision making table are not an exhaustive list and should be used as examples only. And even on the screen that I'm showing you here, examples, these are just examples to guide you like what kind of conditions may lead to moderate complexity or high complexity based on the type of treatment rendered to the patient. As I've stated earlier, the final diagnosis for a condition does not always determine the level of service for the encounter. Documentation of the presenting problem must support the criteria for the level, and also the other two columns on the medical decision making table should be considered, like the data points and the level of risk. The first criteria we looked at was the nature and number of problems that were treated or addressed, the problem points. The second criteria in the medical decision making is the amount and complexity of data that has been reviewed and are analyzed by the treating physician. Let's look at all the elements that would be counted towards the data point calculations. So for the data points, understanding the definitions is important when it comes to review or order of diagnostic tests and other elements. So a unique test. A unique test is defined by the CPT code set. When multiple results of the same unique test are compared during an E&M service, you can count it as one unique test only, which means if you are, let's say for example, patient is undergoing a serial blood glucose values. Okay, if there are three, the blood glucose values were drawn three times, it doesn't mean it counts as 3 points. It's only a single point again because it's the same test that was ordered or reviewed. Okay, and another example could be a CBC with differential, right? So this CBC with differential would actually incorporate the set of hemoglobin, CBC without differential, and platelet count. Next, a unique source. So, a unique source is defined as a physician or qualified healthcare professional in a distinct group or different specialty or subspecialty or a unique entity. Okay, if I have to say unique source, if you're talking about testing and a radiological workup, let's say, for example, laboratory workup or laboratory tests, it could be a urine sample and a urinalysis, or a CBC, which actually comes from a blood sample. So these samples are unique in their source, that from where they are acquired, right? So these should be counted individually. It cannot be a single uh, data point that you count. Now, another thing, the third point is review of all materials from any unique source or external source will count as one element towards the medical decision making. So any review of external document should be external providers or document should be clearly captured in the documentation. So the data points. The data points are divided into three categories. First is the review or ordering of tests, documents, and also collecting history from an independent historian. Each unique test order or each unique test order or document is counted to meet a threshold number for data points. The second is independent interpretation of labs or radiological workup, which is counted towards the medical decision making only when these tests and orders are not reported separately with a CPT code for billing purposes. Okay, let's say a chest X-ray. If the chest X-ray was performed by the same physician who is actually doing the ENM, then you cannot count the review or order of the chest X-ray separately because you are billing for it. Okay, and the third element for data points is the discussion of the test results with the provider who actually performed the service. So, if you're discussing something with the radiologist or the pathologist in detail, make sure that you document it so that you get the credit for the review. So, there are definitions established for each of these elements listed here, and each element has an important role to play when it comes to the calculation of the amount of data that was reviewed or ordered during the patient encounter. All testing ordered during an encounter is counted only for that encounter, and any testing that was ordered previously may be counted when they are actually analyzed. For recurring orders, each new result can be counted for the encounter in which it is actually analyzed. Now, testing includes laboratory services, diagnostic imaging, psychometric or physiological data, and remember that laboratory panels are counted as a single test always. So, all panels should be counted as a single test, not individually. For the term unique testing, multiple results of the same test should be counted as one unique test and not multiples, just like CBC or CMP or basic metabolic panel, for example. Review of external records, communications, and test results can be counted for data points when they are from an external provider or a facility. And discussion of test results requires an interactive exchange, and the exchange must be direct and not through other clinical staff. The provider actually has to speak to the other providers. When it comes to history or information obtained from an independent historian, it would only count when that individual is the patient's parent or guardian or spouse or the primary caregiver. But remember, translation services will not qualify as an independent historian. So anything that you discuss with the patient's caregiver or family members needs to be captured appropriately. Now, the third and the most important element in the medical decision making table, and while selecting the level of service, is the risk of complications and morbidity or mortality of patient management at the time of encounter. We call this as the level of risk in simple terms. So, this is distinct from the risk of condition itself. Now, there are specific definitions established for the selection of the level of risk for the MDM table. First definition is for the level of risk, where the level of risk is the probability or consequences of a medical intervention or treatment. The assessment of the level of risk is actually affected by the nature of the medical intervention or treatment that is considered. For example, a low probability of death may be high risk, whereas a high chance of a minor, self limited adverse effect of treatment may be a low risk. Definitions of risk are based on the usual behavior and thought process of a provider in the same specialty, and trained clinicians actually apply common language terms such as high risk, low risk, or minimal risk. So, for the purpose of calculating medical decision making, level of risk is based on the consequence of problems addressed or treated at the visit, and also include decisions that are related to the need for additional testing or treatment or hospitalizations. The risk of patient management criteria actually applies to the decisions made by the provider during the visit. Now, the second definition is for morbidity, which is a state of illness or functional impairment that is expected to be long term in duration, and with which the patient's function is limited, quality of life is impaired, or there is some sort of a organ damage that may not be temporary despite treatment. This would be the risk of morbidity. The third definition is for economic and social conditions that may influence the health of the patient. Examples, of economic or social elements could include food or housing insecurity, safety and welfare issues, or unemployment, or inadequate education, and so on, similar kinds of things. The next definition is the classification of surgeries. So, the classification of surgery into categories such as minor surgery, major surgery, elective and emergency surgery also plays an important role in the risk level. So, risk classification is based on decision for minor surgery with identified risk factors, or decision for elective major surgery without identified risk factors, decision for elective major surgery with identified risk factors, and lastly, the decision for emergency major surgery. So any sort of surgery that is being scheduled or proposed will also have a bearing on the level of risk directly. Now, another important point or element as part of the level of risk is drug therapy requiring intensive monitoring for toxicity. So, any drug that requires intensive monitoring should be a therapeutic agent which has the potential to cause serious morbidity or death. Monitoring is performed for assessment of potential adverse effects from the drug and not primarily for assessment of the therapeutic effect. Okay, and monitoring should actually follow practice that is generally accepted for the drug, but may be patient specific in some cases. Intensive monitoring may be long term or short term monitoring, and long term intensive monitoring is usually performed on a quarterly basis. Monitoring may include a lab test or a physiological test or an imaging. Monitoring affects the level of MDM for the visit in which there is management of the patient. So, patient should be actively managed with that drug and should be placed under continuous monitoring. Examples may include monitoring for cytopenia in the use of an antineoplastic agent between dose cycles, or short-term intensive monitoring of electrolytes and renal function in a patient who is undergoing diuresis. Okay, examples of monitoring that does not qualify include, for example, monitoring glucose levels during insulin therapy as the primary reason is therapeutic effect. Okay, and unless the patient has a current condition of severe hypoglycemia in such insulin cases, or annual electrolytes and renal function for a patient on a diuretic, the frequency does not meet the threshold. So it cannot be simply to monitor the effect of the drug. It actually has to be to monitor the patient's condition overall for toxicity. So, to summarize the medical decision making table, chart A is for the number and complexity of problems addressed. Chart B here is for the amount or complexity of data to be reviewed and analyzed by the physician. Chart C is for the risk of complications and morbidity or mortality of patient management. We must consider at least two of these three MDM elements from these three charts for the overall MDM. That's how the nature and number of problems, the amount or complexity of data, and the level of risk, all three play together in selecting the overall MDM level. This is what I have for the medical decision making, the definitions, and how the medical decision making should be looked at. Thank you. Thank you for your patience. And I know this is a bit extensive, but a very important piece of information for everyone on the changes for the 2023 evaluation and management services, specifically on selecting medical decision making as the criteria for code selection. Thank you.